Now, it's always great when one of the IDO alumni returns, particularly with something to show us. Again, without any further ado, please welcome one of our IDO alum to talk to you about neglected tropical diseases, Juliette Hoeffle.
Great, well, thank you very much, and I'm really grateful to be here and to speak with you today. So I will introduce you to mass drug administration for neglected tropical diseases, which many people don't know, but is one of the biggest public health interventions in the world. And I will also talk about ethics in that, and I hope I can convince you that ethics is important for One Health as well. So to introduce you to NTDs, so neglected tropical diseases, so I'll call them NTDs and mass drug administration, MDA, because it's quite a mouthful, but don't mind my abbreviations. So to introduce you to NTDs, so why are they called neglected tropical diseases, and why are they in one group? Well, first, it is a very diverse group of diseases. So they're mostly parasites, but there's also a non-infectious disease, which is snakebite envenoming, and so it is a very diverse group of diseases. And why are they grouped together? Well, they have in common that they're chronic and debilitating, so their morbidity burden is way higher than their mortality burden. So this can manifest through, for example, lymphedema for lymphatic filariasis, which leads to disability, or for intestinal schistosomiasis, there's also disability in children. They disproportionately affect populations living in extreme poverty, so they do not only result from poverty, but they also create poverty, kind of resulting in what is called a poverty trap. And as they're mostly parasites, they have very complex human, animal, and environmental life cycles, and linking to the fact that they mostly affect impoverished populations, this makes their control very challenging. So there is no fixed list of NTDs. The WHO recognizes 20 of them in its roadmap that ranges from 2021 to 2030, but the leading journal in the field, for example, PLOS NTDs, recognizes more than 40. So in terms of epidemiology, there are 1.6 billion people affected by NTDs in the world, which is, I feel like it's very huge. Their collective burden, although they don't kill much, but their collective burden is similar and can be compared to one of the big three, so malaria, TB, HIV, AIDS. And if you look at the map here, they're very highly prevalent in tropical and subtropical areas, but they can be found everywhere in the world, really. And what is most interesting, I feel, so if you look at, for example, the redder the color, the more NTDs are co-endemic in that specific country. And all low-income countries, as per World Bank classification, are affected by at least 5 NTDs together. In terms of policy, NTDs have been addressed in the Sustainable Development Goals, especially SDG 3 about health. And there's actually one goal that is by 2030 to end the epidemic of neglected tropical disease, which is a big endeavor. And they also link very well to the pledge to leave no one behind that kind of guides the implementation of Sustainable Development Goals. That's why the WHO has a roadmap for NTDs that spans from 2021 to the end of the SDGs in 2030. So one of the big measures in this roadmap is called mass drug administration, so MDA. So this picture illustrates it quite well, and it actually links to the first talk we've just heard, so I guess it's interesting. So it entails the regular treatment of entire risk groups for a disease, irrespective of individual health status. So people are treated, and they are not diagnosed prior to treatment. The target is historically 5 NTDs. Now there are 10 targeted, so it's getting bigger. Those historical ones, and there are still the biggest ones, are schistosomiasis, soil-transmitted helminths, onchocerciasis, lymphatic filariasis, and trachoma, so mostly helminth diseases, and then, trachoma. So the drugs, are mainly antihelminthics, but there's also antibiotics used, and it relies on large-scale donations by the pharma industry, so it has been started with the London Declaration in 2012, and has been reiterated recently with the Kigali Declaration. The treatment can be done in schools, and then it's usually done by teachers, or it can be delivered as a community-based treatment by volunteers called community drug distributors, CDDs, in central point locations or from door to door. There are more than 1 billion people treated annually for at least one of those NTDs, so that was from 2015 to 2019. So why do I want to talk about ethics in that context? Well, it is interesting that MDA for NTD control has been carried out for decades, actually, even before the early 2000s, and it has received very little ethical attention. So I focused on that during my master's thesis, and we actually published a paper in March, which is the first systematic review of the ethical debate around MDA for NTDs. As a little disclaimer, first, we do not distinguish between the different NTDs, and we are conscious that, it's clear that the diseases are very different, and the way to address them is also very different. But the WHO recognizes MDA kind of as one measure, so that's why we focus on MDA as one measure. And since they affect the same populations, basically, it's also interesting to see it as one. So for the methods, we used the normal systematic review process, very classical. Here's the Prisma diagram. So we did a search on PubMed and Web of Science, title abstract screening, full text screening then, and then we did qualitative analysis of the 60 included full texts. So in terms of the unit of analysis that we used, it was the ethical reasons. So usually arguments are composed of 2 parts, of premises and of a conclusion. So it can be several premises and one conclusion. And so we used those premises that we call reasons and allocated them an implication based on what the author was saying about MDA. So positive, negative, or ambivalent. Then we grouped them into categories that we took from the public health ethics framework by Markman that we felt was kind of fitting after reading the texts first. So this public health ethics framework is composed of several categories, so expected benefits of the measure, potential harm done by the measure, autonomy of the actors, equity, efficiency of the measure, so mainly cost benefit, and then we also included a category for sustainability to capture kind of long-term implications for disease control. So in terms of results, most publications that we found have a very broad focus. So they mostly talk about NTDs in general, and then there are only 5 out of the 10 PC NTDs that are addressed in those publications, which is important to keep in mind for the analysis. And what we found very striking is that the vast majority of first authors were affiliated to an institution based in a high-income country, and those are not the countries where NTDs are the biggest problem, so also important to keep in mind for the analysis. So I will guide you kind of through some ethical issues that we found. It's not comprehensive. If you want to see all of them, please do read our paper. But yeah, it's just some of them. So first, starting with a very classical issue in public health ethics, which is the benefit versus harm profile of the measure. So in terms of benefits, the people who kind of yield this individual benefit are people with acute infection, because they can be treated, they receive the treatment, they are treated, and then they are basically cured of their disease. Then in terms of collective benefit, many authors said that it reduces the prevalence and morbidity of the target disease and averts DALYs also in future generations, which of course is of value. The problem is that most people treated are in fact uninfected, and those do not have any individual benefits of the measure. And people with chronic disease also do not benefit from the treatment because it does not revert their symptoms in any way. This has to be put kind of in context with the fact that there are individual harms, so there are side effects from the drugs, like for every drug there is a side effect, but when you treat a population, of course, those side effects, you will see them, ranging from mild to serious side effects. And if you think about it, people who are treated are usually people living in poverty, so if they have mild side effects, usually they cannot work, and then they're not compensated for the days they do not work. So it has to be thought kind of in that type of context. And there is also a risk of fatal choking on medication in young children. That is mainly due to a lack of like age-appropriate drug formulations for a lot of diseases. So if we look at the collective benefit, well, actually the benefit to risk ratio depends on the coverage. So the more people are treated, the more it reduces the prevalence and morbidity of the target disease, and maybe then the collective benefit becomes higher than the individual harms done by the treatment. But yeah, this all depends on the coverage. And this is important to keep in mind for the next slides. So in terms of equity, many authors characterize this measure as a pro-poor intervention because the drugs are usually unaffordable outside of MDA. Those are low-priority treatments, and people are usually beyond healthcare system reach. But on the other hand, there is an unequal reach in target populations. And for example, if you target school-aged children by giving the drugs out in schools, then you don't reach out-of-school children. And yeah, and it's the same for risk groups that are basically just untargeted by the measure because they're not included in the program, such as adults for schistosomiasis. And this is not a problem in our countries, but if you don't have a supportive primary healthcare system that can give you the treatment if you're sick, then not getting the treatment through MDA if you're sick can be a problem. So usually the measure, as I said, is carried out by community drug distributors. So those are volunteers from the communities themselves. And there are a lot of implementation challenges related to that, and they have they carry a big burden. They have a big role in reaching the communities, but they also happen to be in places where, I mean, there is lack of infrastructure, and usually they are uncompensated, which of course can be a big issue. So implementation context really matters in that case. In terms of autonomy, many authors criticize the lack of community sensitization that is done around this MDA. Which means that people have, I mean, there is challenge, of course, to informed consent, because if you're not informed, you cannot consent properly, right? And then people also tend to refuse the drugs simply. This also links to a lack of community engagement in targeted populations, and again, attention to those CDDs is really crucial in that matter. Also because community engagement does influence coverage, and as we've seen in the first slide, it does influence the benefit to risk ratio of the measure. And then finally, yeah, it was also emphasized that there is an imbalance between the donors and the endemic countries. So one of those quotes is, yeah, the goal strategies and interventions are often developed at the global level, significantly influenced by partners in the global north. So as a last ethical principle here, in terms of sustainability, many authors said that, yeah, indeed, it is a curative measure. So it cures you when you have the disease, but it does not prevent being reinfected by the same disease. and it does not interrupt disease transmission in the long term if you do not do other things to address root causes of the disease. So here one of the quotes: treatment without improving the water, sanitation, and hygiene provision does not stop transmission of the parasites. Some of the children still have to cross schistosome infected rivers to get to and from school. So this is an issue when you think that MDA is often the sole intervention in those contexts, and it has to be repeated and repeated and repeated to be able to yield those benefits. And then linking to the first talk, there is a probable emergence of drug resistance, and this, in an ethical sense, can also jeopardize treatability for future generations, and then you have to think about those and what you are doing now. That's why many authors advocate for a multi-disease, more preventive approach to the problem rather than taking MDA as a magic bullet, which has been the case for a lot of years. So to summarize, there are very few ethics. We found very few ethics really focused publications, but there were a variety of ethics topics addressed in publications and across ethical principles. There are many implementation challenges that are yet to be addressed in policy. Sustainability of MDA is questionable in the absence of structural change, especially when it's the only measure to tackle NTDs. And what I found interesting here is that there is indeed a gap in the One Health considerations around MDA, because a lot of those diseases have zoonotic transmission, for example, schistosomiasis, and animal ethics is not addressed, and people do usually depend on those animals for their livelihoods. So there is a lot of ethical work that could be done in that area. So it is really important to evaluate these measures in a context-specific manner. So in policy, to develop ethics guidelines in a One Health perspective, to consider also integrated control strategies to tackle those socio-ecological drivers of disease. So here the WHO has released a One Health companion document to their roadmap in 2022. So let's see what happens. And then it is important to involve endemic countries more in NTD decision-making, and this is one of the pillars of the new Kigali Declaration. So I am hopeful that it changes, but yeah, let's see. In terms of research, it would also be important to expand this bioethical discourse on MDA, because it is very Western focused at the moment, and to kind of include ethical principles that are more by local researchers and by non-Western philosophies. And to finish, and this is my last slide, I just wanted to reflect a little bit on ethics and One Health and the importance of ethics in One Health. So all of those diseases are what they call syndemic, so they're all co-endemic in the same settings. And this is not by chance. This is because those people face social and ecological inequalities. And this is not just the people, but it's also the animals that live with those peoples, and it's their environment that is infected by those diseases. And this means One Health is a political concept, and it is not just an apolitical Venn diagram linking those three sectors, but you have to think about it in a social scale. And there is an interesting concept, I feel, from Brazil that is called One Health of Peripheries, and that actually theoretizes One Health more as entanglements of multi-species collectives that are more or less privileged in the social space, which is probably interesting to think about when you think about preventive measures and about trying to tackle those upstream drivers. To finish, I think this links very well to the theme of the conference, and I do think that we cannot do One Health without thinking about social inequalities to achieve global health. Thanks.
Thank you, Juliette. So we'll open up the floor to questions now. Yep, over on the left there.
Thank you very much, Juliette. So inspiring. It was lovely. I have two questions. One which is more clarification, because I'm not sure I got the point. And the second one, more on total reflection. When you talk about massive drug administration, do you say that actually people that are not sick also get this?
Yes. So people are treated, there are risk areas defined for certain diseases, and then you define a target group for the measure, and then you try to treat everyone in that target group.
Well, okay.
Yeah.
And the second one is there a similar kind of work that you did on the benefits of vaccination? For example, we know, for example, that BCG is able to protect against TB somehow, but also against multiple other diseases. Mm-hmm. So is there any kind of evaluation of the global benefit of vaccines, generally speaking?
There is quite a lot of ethical work done on vaccination, especially to kind of define which target groups should be included and not included in those vaccination campaigns, depending on, it's the same type of reflection, the benefit to harm ratio, and so there is quite a lot of work. I don't know if there is a global thing about all vaccines, because I guess, it's it's context specific. It depends on the disease as well. So,
and a very last comment that you didn't bring this because maybe it's a little bit of a challenge. I think also the problem, it's political, that's for sure. Yeah. And I think for these neglected diseases, but it's also a problem of money. And I think it's because the big firms, companies, do not want to develop drugs for this kind of diseases. So you didn't really address this in your talk. But I think this is also an important point.
Definitely, and most of those drugs are actually donated by the pharmaceutical companies, and the implementation challenges come from mainly from the lack of money that surrounds those donations, and then in the last steps to kind of provide them to the people. So, yeah.
Thank you.
We have another question in the middle there.
Here, we go here first. Thank you, Juliette. Great presentation. Regarding the pharmaceutical companies, I just wanted to understand what is their incentives of doing these large-scale donations?
Because they're nice.
Really?
They do. I think they do have. Those drugs. They have drugs for neglected tropical diseases, and neglected tropical diseases just don't happen in countries that can afford those drugs, right? So I think it's a route to kind of get their products in the country, and I guess they also get some tax benefits for that, but not advancing myself too much.
Thanks. And one further question: is there gender disaggregated data also?
You mean on delivery or?
The whole chain basically, and also the treatment, how they react, girls different from boys.
Yeah, I've seen some papers address it, so I think that it's kind of in the making. So it has been done in some countries, but it's definitely an area to look into.
Thanks.
Sure.
When we think about targeting populations, I'm wondering, has anyone done any work in terms of informed consent and individual benefits about targeting individuals within the targeted area, so that you're not just doing a mass drug administration in that area, you're saying within that area, I am going to focus on the 10 to 15-year-old children because they're the ones in the water, and I'm not going to treat everyone, and therefore the informed consent is more useful from that aspect.
Yeah, there are measures. So, for example, in schistosomiasis, it's usually targeting school-age children. There are measures targeting that specific population groups. But then again, the informed consent, there has to be sensitization in order for people to be able to consent to something, because the word informed is indeed important in that concept, right? So but there are some measures targeting specific groups in general. The only thing that is not done is diagnostics before treating. Yeah.
And did we have any questions from the online chat? No? All good? Join me in thanking Juliette once again.
Okay.